so much, Dr. Contreras, for speaking with me. How are you today?
Doing well. Thank you so much for having me. Here.
Yeah, so I'm really interested in learning a little bit more from you about brachytherapy. I had heard about it, but I did a little more research just to educate myself. So I guess my first question for you would be, how long has brachytherapy been available as an option?
So brachytherapy is one of the oldest types of radiation that actually has ever existed. It was first discovered in a way by Marie Curie in the late 1800s, and the first use was actually for skin cancer in right before the turn of the 19th century. So it's been used for over 120 years. In GYN cancer specifically, the first reported use was in 1905. So it's one of the longest types of radiation treatments that we have available for patients.
Okay. You said one of the longest running types?
Yeah, so it's one of the oldest types of radiation and the first ones that we use because it's so in its at its basic principle, it's using a radioactive source to deliver radiation locally to either a tumor or an area that's at risk. So for GYN cancers, it's been commonly used since like 1905, but really since the 1920s to 40s is when we started seeing it used more frequently. And around that time, they developed various techniques that are actually still somewhat used today. So over 100.
Okay. How has it improved or changed over the years? I mean, I imagine what we're doing now is probably different from what we started with.
Absolutely. No, you're completely right. So the actual treatment itself hasn't improved significantly because we're still using a radioactive source at a tumor, in a tumor's per se. What has improved is our ability to plan the treatment. So we're able to use more advanced treatment planning systems that allow us to shape the dose of radiation a lot better. Something else that we're doing now versus 100 years ago is, of course, we use advanced imaging to plan a lot of our radiation treatment. So back in the day, like even as little as 10, 15 years ago, for GYN cancers, we would use just plain films like old school x-rays to plan these types of treatments. But these x-rays don't really give us any information about the soft tissue, the tumor, and all the surrounding really important structures that we have, particularly in GYN cancers. So what we do now, and what's really made the biggest difference, is the use of MRI. And it's using MRIs that we're able to better target these high doses of radiation because we can actually see where tumor is located or the area that's at risk. We can actually visualize it versus in a plain film. So MRI has really allowed us to be able to better shape the dose of brachytherapy and maximize the really great physical properties that it has for the treatment of GYN cancers specifically.
Now, I've heard of them using like MRI live action, or I'm blanking for the word, real-time MRI, there's the word. Is this real-time MRI that you use when you're placing the device, or do you do a MRI imaging and then place based on that?
So to place the device, we used ultrasound. Placement. So the ultrasound helps us identify cavity and really place the applicator. After the applicator is placed, that's when we use the MRI itself. So we will image the patient with an MRI or with a CT scan after the applicator is in place, and that's the scan that we will use to plan the radiation treatment itself.
Okay. So you can adjust where the radiation is going to go after the device has been inserted.
Exactly, yes. So we place it and we want to place it as close to the area or into the tumor. But then we can actually specify the amount of time that a radioactive source spends throughout the device And by modulating the time, that's really how we can create higher doses of radiation in different regions, or lower the radiation doses in other areas. So we can definitely modulate and shape and really change the dose of radiation after the device is placed.
That's incredible. That really is. So who would be a candidate for brachytherapy?
Yeah, so brachytherapy is really widely used. So specifically for GYN cancers, it's used in cervical cancer, endometrial cancer, vaginal cancers, and even vulvar cancers. Outside of the gynecological oncology world, I use brachytherapy for some of my breast cancer patients. And then outside of women's health, brachytherapy can be used throughout a variety of disease sites. So we use it for skin, for prostate, for esophageal, for sarcoma. So it's a really broadly used type of radiation.
Okay. So who would be your optimal candidate? Because I think on this article we're really specifying cervical cancer. Who would be your optimal candidate? Or on the contrast, is there anybody that wouldn't be a candidate?
So for cervical cancer specifically, if a patient is not having surgery as their treatment and they're getting chemotherapy and radiation for the curative treatment of cervical cancer, most patients should receive brachytherapy. It should only be a small proportion of patients that cannot get brachytherapy for specific reasons. So whether their tumor is too advanced or you really can't place an applicator to deliver it, but the standard of care should be that most patients with cervical cancer receive brachytherapy in addition to external beam radiation. Now, if patients have surgery, and if after surgery they had a lot of risk factors where they require more radiation, these patients may also be candidates for brachytherapy, because really what brachytherapy allows us to do is to really concentrate a really high dose of radiation in one specific area, and limit dose to the surrounding structures. So it's the only way to give the high doses of radiation that we really need to provide our patients with a cure from their disease.
So you would say that in most cases it's going to be used along with external beam radiation, and in some cases maybe even chemo?
Correct.
Okay.
Yeah, so the patients that are not surgical candidates for cervix cancer, so if it's a big tumor, if they have lymph node involvement, or if the primary tumor that is in the cervix has started to grow outside of the cervix, those patients really should not have surgery. And the standard of care is chemotherapy with radiation. And that radiation should always include brachytherapy. There really should be very specific reasons as to why those patients don't receive brachytherapy, but it's the only way to give patients the best chance of cure from their disease.
What would be, I noticed that there's a couple of different options with brachytherapy, that there's low beam and high beam. Can you elaborate a little bit more on what the differences are?
Sure. So from a brachytherapy perspective, like I mentioned previously, we're using isotopes. So there's two different types of brachytherapy, and that's really based off of the isotope that's used, so the type, the radioactive material that's used. And one of them is low dose rate brachytherapy, or LDR. The other one is high dose rate brachytherapy, or HDR. Now, there are a lot of differences between the two. Historically, so when I talk about 100 years ago, really the only type of brachytherapy that was used was LDR, or the low dose rate brachytherapy. In that type of brachytherapy, a patient is either permanently implanted with a radioactive material, or a radioactive material is placed and it's left in place for several days. So patients required several days of treatment to receive the total dose of radiation that they needed. In patients that undergo LDR brachytherapy or the low dose rate brachytherapy, we have to take a lot of precautions because they are actually radioactive. So you have a radioactive isotope implanted in the patient. So if the patient is hospitalized, they'll often be placed in isolation. If they're deemed, if they can be released to go home, we often give them a lot of precautions. So they may be asked to stay away from loved ones, family members, pregnant women, or young children for a couple of days. Now, we contrast that to HDR or the high dose rate brachytherapy. That has been used more frequently in the last couple of decades. And in that situation, we use different types of radioisotopes. And one of the best, honestly, the biggest advantages of HDR is the fact that the treatment is delivered in just minutes. So instead of a patient going home with radioactive seeds or having an implant placed in the hospital for a couple of days, we actually bring them in, they have the same procedure, and when we deliver the radiation, they're usually in a room alone for anywhere from 5 to 12 minutes. So it's really minutes. And after the patient gets the treatment delivered, everything is removed and they are no longer radioactive. It's a much faster treatment that's delivered. Patients are not radioactive, so there's no risk of them being in close contact with family ones or loved ones. So those are primarily the main differences. And because of that, we've seen a change in practice patterns in the US. And so most sites will use HDR brachytherapy for cervical cancer patients.
Okay. So the high dose is more commonly used now.
Correct, yes. And because it's really a lot more convenient. So when we looked at outcomes for patients, the outcomes are the same. They seem to be exactly the same. But it's a much more convenient treatment because instead of being hospitalized over 4 days, patient come in for 1 day, they have their procedure, they have their treatment, and they're able to go home versus staying in the hospital for several days.
Right. And so the patients that would need to worry about taking precautions at home would be the patients that receive the low beam brachytherapy.
Yeah, the low rate.
So would there be a specific patient that you would recommend that treatment for versus the high beam?
For gynecological cancers, no. There's really no evidence to show that one is better than the other. There are a couple of centers throughout the country that still do LDR. We do high dose rate brachytherapy, and most places will do high dose rate brachytherapy. So in gynecological cancers, there's not strong evidence to show that patients should receive LDR. So really go ahead.
The HDR is definitely the more common one then for good reason.
Correct, exactly, yes.
What would be some of the short-term and then long-term effects of brachytherapy?
Perfect. So brachytherapy is very localized treatment. So when I think of side effects for my patients, they're really very focal. So when we think of short-term side effects or side effects that patients may experience during treatment or shortly after completing treatment, particularly for cervical cancer, I think about urinary frequency. So patients may feel like they have to go to the bathroom a little bit more frequently. They may feel like they have some urinary burning, or it may be a little bit painful when they go to the bathroom. We can also see some urinary urgency. And then in that area, we also have the rectum and the sigmoid, so your bowel. Because of that, our patients may experience some diarrhea. And lastly, when you're treating the cervix, you also affect the vagina itself. So some patients can have vaginal discharge during the course of therapy. All of these side effects are usually something that we can manage with medication alone. We see our patients frequently during the course of treatment. So all of these can be managed with over-the-counter medication or medication that we prescribe.
Mm-hmm. What about long-term effects?
So long-term side effects have to deal more with the fact that radiation causes a lot of inflammation and scar tissue. So when I think about long-term side effects for my patient, again, we think about the bladder. So in the bladder, they can still have some urinary urgency or incontinence. We can still see a little bit of rectal irritation. And then lastly, one of the main things that we cause is we can cause scar tissue in the vagina. And this can lead to vaginal shortening. So the vagina can become smaller or shorter throughout, months to years after radiation is delivered.
Mm-hmm. So what can be done to treat that?
Yeah, that's a great question. So, when I talk about vaginal side effects, you have to think about sexual side effects, right? Because this is going to affect a woman's ability to resume her normal sex life. So we have a couple of different things that we can do for that. During the course of therapy, I will slowly bring this up with my patients so they're aware that this is a side effect, because right after, we always talk about using something called a vaginal dilator. So a vaginal dilator is exactly what it sounds like. It looks like a plastic tampon, and we place this. I ask the patients to use this after they've completed their radiation treatment for the rest of their life. And what patients have to do is place this inside of the vagina to help keep things open and patent. We know that this is a way for them to be able to potentially go back to having a normal sex life and enjoy their everyday sex life. Other things we do is we talk about lubrication, or ways to approach sex in a manner that's not painful to them. So it's really, it becomes more of a family discussion with their partner or their significant other, where we talk about ways to really improve any symptoms that they may be having, or we can often send them to see a sex therapist also, which is necessary in some cases.
Mm-hmm. And there are physical therapists as well that work with that kind of like pelvic floor pain and discomfort as well. Exactly. And vaginal dilators.
Yeah, so we have, so it's pelvic floor rehabilitation. So that helps with a lot of the urinary issues, but some places also specialize in sexual dysfunction. So they can talk to patients and go over different ways to help with, ways to improve their sex life long term. So yes, patients have lots of options. And I think that's one of the main reasons why, every patient should ask about additional support services at the place where they receive treatment, because these are a lot of the things that patients may not think about initially, or may not think are important, but long term, after a patient is cured from their disease, it's a very normal aspect of their day-to-day life. And my goal, at least, is to hope that my patients go back to their normal baseline.
Right. I would imagine, never having been diagnosed with cancer myself, most patients, when they're first diagnosed, their primary concern is, how do I just get rid of this cancer? Is it treatable? Am I going to survive?
Exactly.
They're not really thinking about long-term down the road. They just want to think about, hopefully surviving their diagnosis.
Yeah.
So what kinds of questions would you recommend? Obviously, you had already mentioned additional support services. But what other questions would you recommend that a newly diagnosed cervical cancer patient discuss with their physician?
Yeah, that's a great question. For cervical cancer specifically, I think first we have to focus on the things all patients should ask. So what specific type of cancer is this? So getting a clear picture of their diagnosis. Then I think it's important for them to ask about, the extent of disease. Where exactly is this cancer? Has it spread anywhere else? And then after you have that information, I always encourage my patients to ask about treatment options. Often when you go to see a physician, you may get one specific recommendation, but it's important to ask, are there other options for treatment? Especially in ladies with cervical cancer, because often women may come in with more advanced disease and surgery may be recommended when it's not necessarily the best treatment option for them. So I think in a cervical cancer diagnosis, the most important thing to understand are, what are my treatment options? Is surgery the only answer in this situation? Because oftentimes it may not be the appropriate path. And then after they have a better understanding of what treatments options that they have, I would ask about side effects and prognosis. So, is this treatment a curative treatment? Is this just palliation to help with symptom control? What's our goal of care, right? And of course, especially, in all cases, side effects are important, but in someone that has a curative cancer, patients really need to ask about side effects, and it's really the long-term side effects that they may not focus on necessarily, like you mentioned, but those are the ones that can really affect their quality of life. So side effects are incredibly important. And lastly, support. What other types of cancer support do the patients have based on wherever they're being treated?
Right. Were there any other key points that you didn't get an opportunity to bring up? Anything else you'd like to make sure that we drive home?
Yes, please. So, in cervical cancer, recently, so like we talked about, brachytherapy is such an important component. So brachytherapy allows us to give almost twice the amount of radiation that we give with external beam. Now, over the last couple of years throughout the US, there has been a trend to try and decrease the use of brachytherapy. So these women with cervical cancer, instead of getting brachytherapy, would just get a much longer course of external beam radiation. And that is absolutely not appropriate. We have evidence now that shows that women that do not get brachytherapy for cervical cancer are more likely to die from their disease. So they are less likely to have a cure. So brachytherapy, I cannot stress how important it is. And not every radiation oncology facility offers it, so it is a little bit more specialized. And that's one of the reasons why there was, an attempt to pull away from brachytherapy. But really, all of these women should get brachytherapy because it's the best way to guarantee the best outcome. Now, it's not just about cure, but in women that do not get brachytherapy and instead get only external beam radiation, we also know that they have significantly more side effects. So there was a study published from UT Southwestern where they tried to replace brachytherapy with high doses of external beam radiation. And ultimately, what they found was that patients had a lot more toxicity. So they had higher gastrointestinal toxicity, so diarrhea, even fistula, so abnormal connections between the surrounding organs and the vagina. So not only is brachytherapy absolutely necessary because it definitely provides patients with the best chance of cure, but it's the only way to really deliver the doses of radiation that these women need, while maximally sparing all of the normal and important organs in that area, like the bladder, rectum, which can cause all of those side effects that will affect the patient's quality of life down the road.
Uh-huh. And you said the reason why maybe there was a trend towards using brachytherapy, if I understood you correctly, is because it is kind of specialized and maybe not offered at all cancer centers?
Yeah, so some cancer centers don't have access to brachytherapy. So, the trend to move away from the use of brachytherapy was really, that's part of the reason why we believe that there was that push. So cancer centers may not have access to brachytherapy, or you don't have the expertise. So you do need a physician that has experience doing these procedures because it is slightly different than what we do in everyday radiation oncology. So it's easier.
I'd love to have that article, that study that you mentioned about the women who get the external beam radiation only and have the, increase in toxicity. I'd love to have that to cite.
Yeah,
Is there any way you could do?
I can send you a couple if you'd like. There's some SEER database papers showing that women don't live as long and everything. I can send those your way.
That'd be great to have. I'd love to have that. And then do you by chance have any kind of visual aids that I might be able to use just to kind of help people see sort of what brachytherapy is, above and beyond just my description of it?
Sure. So like almost images of their applicators?
Yeah, or like a just artist depiction, something that kind of helps people visualize what it is.
Sure. Yeah, I can send some your way. I can find some for you. We have some pictures that we use in clinic, but I can definitely get some better ones for you and email them. If that
Perfect.
Wonderful.
All right.
You can send those to me. I'm happy to share them.
Okay.
I'm so sorry. Just happy. Feel free to share them with me, doctor, and we'll make sure to get it to the reporter.
Perfect. I will. Thank you.
And I wanted to share. This is Erin. I just want to share that that Kyra Lee is going to be speaking, Dr. Contreras, with Shalat. Shalat. I don't know how to pronounce her name.
Yeah. Wonderful.
Yeah. Is there anything that you think that Kyra Lee should ask her that you think would be important to learn more about her experience, or maybe even like that, as you said, to know the treatment options available, because she did go through chemotherapy first. Is there anything that you would want Kyra Lee to touch upon?
So I think with Ms. Mel, she had a bit of her presentation wasn't typical. It's not normally what we see in cervical cancer, but it might be great to get her perspective on the procedure itself, what she experienced during the day, how she felt, and kind of like the patient's perspective of that day, because it can be a little bit longer of a day. And, I can talk about the side effects, but I've never felt them myself. So I think that might provide patients and readers with a better description of what patients can experience or expect.
Mm-hmm. Yeah, sounds good. I like that angle. All right. Well, after I've talked to your patient, I am going to go ahead. I'm aiming to get this up and running by the middle of the week. So I'm going to get this written up, and I will get a copy of this to Erin. So Dr. Contreras, you'll have a chance to just kind of look over it before it gets published.
Okay. Perfect. That sounds great. Thank you.
Yeah, you'll have a chance to look over it. I'll get it to Erin. Once I do get it to my publicist, for source review, I do try and get it turned around pretty quickly. I like to have it submitted within